just a second. I'm missing a piece of information. So it should be able to have both of the your video and you talking. Yeah, I've got it. So how I'm seeing it is you next to, and that's, I want to make sure I'm seeing it as what a gallery would see it as. Attended view, standard. Okay, no, it shows you there. So when I'm looking at it, you'll be little, you'll have your presentation and you'll be little and off to the side. So that's how that shows. There are other fancy ways, but I did not bring a green screen because I don't have one. Where we would put you in front of the PowerPoint presentation, have you talking to the PowerPoint presentation?
Yeah.
I don't know if that would be.
So I will just keep these and you're in a practice session. So how do I go to the next slide? This one. Okay. And then this, I'll just see these slides one more time. So where are the notes here?
That's what I was looking for.
But I can keep the
Yeah. We have the
slide 1, slide 2. Notes start from this slide. Slide 4. Okay. I'll just take this out.
Yeah.
This way I have, or I can
Please
just
take it here apart. It's as you have the.
I'll just go through this. Right.
Hi, Ravjot.
Hi, Dr. Singh.
How are ya?
I am good.
Is Krista on too? Says, can you help us
Yeah,
the
here. Yeah, we were just going through the presentation.
Yeah.
Okay, do your thing. You don't really need me till like 5:30, right?
Correct. I just wanted to make sure that we had you nearby.
Yeah. All right. I'm gonna log in on my laptop, but I'm working on my laptop, so I'll leave this on for now for like the next 5-10 minutes or so. I just got 2 more echoes I gotta finish up. Or I mean, I can even do it on this thing. You guys can see me, right?
Yeah, we can see you. Yeah.
But I'll try to do it on my laptop in just a minute. You do your thing.
Okay.
I'm gonna mail it over to you.
Okay. What does the background mean?
It's so you know how you can see like that window picture, my thing, it creates that window picture behind you.
Right. So these 25 women, they log in to Zoom and they sign up for the seminar, which is sort of free for them.
It is free for them.
Okay, okay.
And I've collected their
Names,
names, their email addresses, and their home addresses.
okay,
So tomorrow I'm going to send through saying, for everybody who didn't attend, so sorry if you missed it. Here's the video, you can watch it again.
okay.
I'm also going to push this out to Facebook. So it'll be playing on Facebook at the same time. Or I can just get that around. That's guaranteed analysis. It's where we do right now. Are you still in the practice session or did it spit you out?
You're in a practice session, it says here. Yeah, you're screen sharing. That's what it's saying.
It's, I dropped out my internet for some reason. It stopped connecting to the internet. So I That background come through.
No, let's take a look at the email. 1 second. Sure did. You send it. Click here to join. Is that?
No, it would be, it would come from me, and it's just one image and an email.
Let's me just double check. I got a invitation, like the previous one starts in 1 hour.
Like, watch, like, tomorrow, and I like 15 emails, and then I'm making, like, backgrounds and stuff. If people like registering. Still, it's awesome.
Zoom background. Okay, I got it. So I download the background.
And the
So photos. How do you want to open this file? Photos.
You want to save it? You want to save it in your desktop.
So how do you want to open it through photos? Okay, let's just open it through photos.
Then you can always.
No.
It's okay. So yeah, go ahead and download it. All right, go ahead, close that. There's going to be a little drop down arrow, little drop down arrow to the side because we want to download it to our downloads. Yep. Stay save attachments. All right, you're done. Okay. And then click on downloads. And in Zoom, just down in here.
Zoom.
Yeah, Zoom the, yeah, it's okay. Zoom the app.
This is it.
Yeah. There's this little plus item here. That image. And put it down. Oh, it's not going to go wrong. Oh, it's Evan's problem earlier. That's okay. I try. I don't know why it's not working. Maybe it's not this weird. Bet you more than anything, it's like a paid feature. And that's why they don't, that's why it doesn't work.
This I like this actually.
You like the blurred? Okay,
Yeah,
yeah, let's do it.
That's super.
Because it won't be me in there.
Okay.
So it should just be able to focus on you.
Now, how do I bring the slides?
Sure, yep. So we're going to go back to share screen.
Okay.
And then your screen that you're sharing is going to be the PowerPoint presentation. So this is where we go through and close windows. Go ahead and hit just click out of here, hit cancel.
Okay.
Let's go ahead and start closing some of the windows you have.
So leave the meeting for a second.
Yeah, you don't have to leave the meeting. You can actually just minimize it. So we've got, I'm going to close. I click. Let's close email. Oh, it's just how much I'm used to working with a Macintosh. This window. Windows. now you should have this and Zoom.
So we'll just keep it here
And so when you're ready,
and just click on share
share
screen.
screen, and now you've got your PowerPoint presentation right there.
Okay.
So it's ready for you.
Can I do it one time?
Yep, go for it.
Share screen and then PowerPoint. And then bring it on and then say share, right?
Share. I should be able to see you. Is it sharing right now?
It is share screen and it shows up. It shows women in heart disease and just click on that and click share, right? And then it'll show up the presentation.
Yeah.
Okay.
Go ahead and bring your laptop closer to you so that you're on the bottom corner of your screen.
Closer to you.
Yeah, so we're gonna position it where you're in the middle of your. There you go. There
Like
you
that?
go.
Okay.
Awesome. Testing 1, 2, 3.
So I'll take the mask off, right?
Yep.
Just take it off.
And we're 6 feet apart. you
So
have to be
we're good. No, it looks beautiful. Yeah. This red color is nice. I have dull colors on. So the red color is bright. It's bright. It's bright. Yeah.
You got anybody on yet, or is it just us?
There are. I don't see any people in the waiting, but
Okay. I've got one last thing to do, but just let me know when you're ready. I've got you unmuted, so
okay.
I'm not leaving my computer. You're gonna do great, Ravjot.
Yeah, hopefully this should go well.
It will. You'll do great.
Thank you, Dr. Singh.
Absolutely.
All right, it's 5:30.
Go ahead and start the webinar.
Do you want me to start or not yet?
Give
Not
them a
yet.
couple of minutes to get on.
Yeah, you tell
We'll
me
go
when.
ahead.
Yes, sir.
You just tell me when.
Good evening, everyone. I see you logging in. We're going to give everybody a couple of minutes just to attend, and then we'll get things going. Everyone, thank you for your time to attend the webinar. Very excited to hear from you and to learn a little bit more about you. My name is Krista, the Public Relations Department here at Cuga Health. And if you are not familiar with Zoom, there are two functions on the bottom of your screen. One is the Q&A function and the raise your hand function. And so as you have questions, go ahead, put it in the Q&A area, and we'll go through and answer those towards the end of the presentation. That time will take you off mute and start a conversation. At first, I would like to introduce Dr. Amit Singh. He is the medical director for the Keuga Heart Institute and the physician practice leader at the Keuga Heart Institute for the Keuga Medical Associates. Dr. Singh.
Thank you, Krista. Can you guys hear me? Can I get a thumbs up? Ravjot, can you hear me? Okay, good. Welcome, everybody. We're excited to have you. Before I get started, though, I have one question to ask. You got to make sure we only allow people who have beating hearts at this presentation. So as long as you have a beating heart, you're more than, and a human, you're more than welcome to this presentation. As Ms. Casper mentioned, I'm Dr. Amit Singh, the medical director of the Keuga Heart Institute, and I'm privileged to perform in that fashion and several other leadership roles. But I'm here today with the exquisite pleasure of introducing my new colleague, partner, Dr. Dr Chawla. Dr. Chawla comes to us, she did her medical school in India and is wonderfully trained. And if you want to look at the who's who of where to do your cardiology training, Dr. Chawla's done that in New York City, in Chicago, in Washington, MedStar, Georgetown, wonderful, University of Iowa, wonderful places. Dr. Chawla has a unique expertise in congestive heart failure. To give our audience perspective, and I know because I looked it up when I was recruiting her, there's roughly 1,800 or so people who have cardiac transplantation and cardiac congestive heart failure board certification. Only 1,800 in all of North America. Guess what? Dr. Chawla is one of them. So we're thrilled that she's joined us. It's been a few months, and she's going to speak today, give a talk for our community on heart health for women and what an important topic it is, and trying to, I would say, redress some of the gender inequality that we have had in cardiology over decades, whether it was intended or not. But, and I do believe it was unintended, but she's going to help. And we really know, because heart disease is a big problem for our ladies in our lives. With further ado, Dr. Chawla. You're still muted. Hold on. I don't know if maybe I have to do something.
Mute. Yes.
Okay.
I think I'm still. Good evening, everybody. Thanks for being here. My name is Ravjot. I grew up in India. I have long family connections in Long Island. My parents moved here in the 70s. I did my med school there. My cousins went to med school in New York, and I moved here for residency. I did my residency in Beth Israel, and then left for further training in Chicago and Baltimore and DC, and I'm back in Ithaca now with the pandemic, wanted to be close to family. So I'm really excited to be giving this talk for you. The talk is titled Heart Health for Women. I just want to talk about a patient that, I saw today, a woman whose husband actually was having new onset atrial fibrillation. She said her brother-in-law had a heart scan at a cardiologist's office somewhere and was told everything was fine, and then had a heart attack and passed away. So she was really anxious. So this presentation is tailored to women, but feel free it also covers all other people in your lives, like your extended family members, your husbands, and so forth. So I will start the slideshow now. So this is our first slide, which is our introduction, which I said I am from originally from India and extended family up in New York, and I moved here just to be closer to family with the end of my extended training, right? It doesn't apply to women, it applies to everybody. So going gender specific, in women, heart disease and stroke kills about 1 in 3 women. but it is 80% of these deaths are preventable. That means if you screen for it, look for symptoms, do primary prevention, you can prevent most of the disease. So most of my slides would be split in two halves. One is primary prevention and one is disease prevention. Primary prevention is knowing people who are at risk for having heart disease, all the women who have high blood pressure, high cholesterol, their moms or their other relatives have heart disease, right? And disease prevention is somebody who actually has a disease and what to do to prevent death from heart disease, which is a killer in women. 1 in 3 women have that. The first again, so the first thing we'll talk about is how does it prevent? And generally it is not heart symptoms in women are different from those in men. Men will generally present with more typical symptoms, which will be chest pain in the center of the chest. It radiates down the arm and jaw. It's associated with shortness of breath. It gets worse with exertion. It can also present a heartburn or indigestion. When my program director trained, which was years ago, right, he would say we would ignore women in heart disease as, you're doing drama, or this is not typical, or they're hysterical, or they're anxious, or borderline, or something like that. But most women may not present with chest pain. They generally present with GERD-like symptoms, right? That is very common, indigestion or gas-like pain. They can also present with pain, which is between the shoulder blades. They can present with dizziness, which is not common, and also more fatigue and sleep disturbances. Fatigue and unusual, normal things, normal activity that you were able to do before, now you're not able to do. So any symptoms of chest pain, shortness of breath, not able to do usual activities, feeling low, and most importantly, gas pain, are signs of heart disease and should prompt. Now, what are the risk factors? These are symptoms. So if somebody has high blood pressure, diabetes, morbid obesity, postmenopausal, family history of heart disease, then those are people who are at higher risk. And how do we diagnose here? So when you come in, you can come in through two ways. You can come in through our office, right, which will be more not an emergent way. You want to know your risks of having heart disease and to prevent it. The other would be as inpatient, where the patient is actually having a heart attack. So the tools that we generally use in outpatient are lipid profile and electrocardiogram, and that is something your primary care doctor would generally do. So they will check your cholesterol, they would do an EKG every so often. If they find that is abnormal, then they may consider referring you to a cardiologist, right? If you want to come by yourself, we can also look at your lipid profile and sort of give you what we call as ASCVD score, which tells your risk profile, wherein we put your blood pressure, your cholesterol, whether you're diabetic or not, whether your family history of smoking, and give you a risk for if you're going to develop heart disease over the next 5-10 years. And the reason it's important is because lowering those risk factors will eventually prevent heart disease from happening. I can give you an example of a woman. She's morbidly obese. Her mother has heart disease and went through a quadruple bypass. I saw her in clinic, and she was complaining of chest pain. She's a bus driver. We cath her. She does not have obstructive heart disease, but she has mild little plaques. Now, why it's important is because if this wasn't found and this carried on, eventually she would have obstructive heart disease many years down the lane like her mother, and she would need bypass. How do we look for further screen? Like once the lipid profile and electrocardiogram are abnormal, or you're having symptoms like chest pain, shortness of breath, gas-like pain, we would do a stress test and an echocardiogram. If you come in through an inpatient setting, we also do troponin for myocardial infarction and BNP, which is for heart failure. So these are the biomarkers or tools. It's almost like getting a mammogram to prevent breast cancer. It's important to get a lipid profile, electrocardiogram at your doctor's office, and just ask them, if you're curious, you'd like to see a cardiologist, just to risk stratify as to what your risk score is over the last 5-10 years. So the question is, first comes primary prevention. So that means this person does not have heart disease. Like they don't have any manifestation of heart disease. They are not, they're not in imminent, nothing has happened yet. So how do we prevent, what are the odds of my having heart disease? So the key factors are family history, what age did your parents, your mom and dad have heart disease, and what your cholesterol profile is. In your lipid profile for women, we look at bad cholesterol, which we call as LDL. So I say lower for bad, L for lower, which means it should be low, and HDL for high, higher the better. So HDL is a protective factor, and generally we being women, we have estrogen. So our HDL is high, and LDL, if it's greater than a certain amount, and generally a cutoff value will be 100, 130, you can say without risk factors, then that's somebody who should see a cardiologist and be started on medication. Exercise decreases the LDL and increases HDL, so that's important. What are the other risk factors for heart disease? Having a history of smoking, having diabetes, having hypertension, right? Diabetes is generally considered an equivalent for CAD. It is also, and generally we recommend for them to have the lower cholesterol, that means the bad cholesterol, more low the better. That's called LDL. So we want it to be below 70 if a patient is diabetic. Sometimes women ask, just hormonal replacement therapy help me prevent heart disease in the future? Yes, estrogen does deplete HDL, and there are some studies which says that it is preventable, but that doesn't mean it's for everybody. Remember, nothing is for everybody. So people who have coronary artery disease, who have a history of stroke, may not be candidates. And I would love to see these women come to me so I can re-stratify, and so we can have a conversation just about your heart health in general. And this is an example of a stress test. What you see are, images of your heart. It's like a little donut, right? And it shows blood flow in rest and stress. And this picks up disease, which is more than 70%, right? We're going to have a new scan. We have a new scan, a scan here called a CT, calcium CT score, and we're going to have a calcium angiography. So anybody who's a smoker, whose cholesterol is high, generally older, would want to get re-stratified, you can get your calcium score. I came from DC, and generally the patients we see are mostly senators. One of my patients was a Reaganomics, the author of Reaganomics, Ronald Reagan's economic advisors. So we generally reference the president as a patient. So for example, Dick Cheney got a transplant, but he had advanced disease. And Donald Trump, his calcium score was 100. So somebody like that, doesn't have heart disease, would be on a statin, right? So this is what a stress test look like. An echocardiogram will be a more visual of this thing. Then is pregnancy and heart disease. What happens in pregnancy? So young women, I saw one of my colleagues' patient, a woman who was having very fast heart rate when she was pregnant, right? So generally with pregnancy, our cardiac output increases because blood flow goes to the fetus, right? So we look at women who have hypertension, diabetes, women who have Marfan syndromes, enlarged aortas. All those women come here to get care and to see whether, in pregnancy is normal. There are some congenital women who can come here to see if pregnancy is a good idea for them, then whether they need C-section. And what is of most interest to me is for Spartan Cardiomyopathy, where the heart essentially fails from having heart disease. And that happens, the question is whether you are going to have a second pregnancy or not. So if you have any pregnancy and heart disease questions, especially if you're a young woman, one of my friends, my personal friends has, I come from India, had rheumatic mitral valve disease. So and it was never picked up when we were in med school, but it was picked up because she got short of breath during pregnancy, and she got a valvuloplasty and she did okay, but pregnancy, she did not have a second child, right? So there are things like HELP syndrome, high blood pressure, preeclampsia, eclampsia, control of diabetes, monitoring your kidney function during preeclampsia, eclampsia, postpartum cardiomyopathy, making sure any kind of tachycardia, shortness of breath, chest pain, the same symptoms that you would have when you are not pregnant. For people who are generally older, is hormonal replacement therapy necessary? It's good. Does it have side effects? Yes. Is it for everybody? No, right? So certain people who, in whom it's not indicated, is people who have heart disease, coronary artery disease, or CABG. This again shows an echocardiogram, which is a test we do to screen disease. What we see here is a mitral valve that is taken from rheumatic heart disease. This is a particular interest of mine, that women who have rheumatic disease, mitral valve prolapse, they generally present with chest pain, palpitation, shortness of breath. I would like to see more of them. So if you have any of these conditions and would like to come here and see me, I am happy to see you. Couple of stories, generally, I have a lot of heart failure and transplant experience. That means I see people who develop shortness of breath, who it builds up in their lungs, and, we diurese them. And in women, what's most common is, elderly women, your mom or your grandmothers, or one of you who's elderly here, they present with HFpEF. That means their heart is normal in function when you look under the echocardiogram, but it doesn't relax. So, every time when the top chamber of the heart empties into the bottom chamber, it doesn't relax as much. So they present with shortness of breath, leg edema, and most commonly atrial fibrillation, right? I've seen a lot of ditch toxicity in women from it, because they're generally put on atrial fibrillation as they're not very mobile. In these kind of patients, hypertension control is essential, frequent visits to the doctor to prevent more inpatient visits, like more visits to the hospital when the person is sick. Also, the question becomes, what do you do in people with atrial fibrillation? So there's a score that we use to assess to prevent long-term stroke, and that is called the CHADS-VAS score. And the CHADS-VAS score includes, certain criteria, like what is your age? Are you a woman? Do you have diabetes, or vascular disease? That this thing. And there is a newer device that we would start implantation soon, which will be CardioMEMS, and that is a little tiny grain of rice that you put in the pulmonary artery, and it measures pressure. So what happens in people who have issues with fluid overload, such as this elderly 80-year-old woman, instead of coming for repeat inpatient admissions to the hospital, they can stay at home. Somebody, from the audience, a couple of questions were submitted to me, and one of the questions was, is atrial fibrillation genetic? And the answer is, there are some genetic reasons for atrial fibrillation, but most commonly it's because of factors such as coronary artery disease, hypertension, or it could be iatrogenic, right? Syncope, this is common. I see a lot of young women coming from Cornell saying they feel their heart is racing or they passed out. And, there is some neurocardiogenic syncope or cardio-inhibitory syncope, which we diagnose with the Tiltable Test. Some of these people have epilepsy or this thing. Generally, we will put them in a little monitor called the Holter monitor for like a day, or an event monitor for a couple of weeks or a month, and see if there is any arrhythmogenic cause. There is a test known as Tiltable Test, which we don't do here, but we refer people out. And that Tiltable Test shows whether, will show the table is raised from 0 to 30 to 60 to 90 degree. And from lying down to standing position, if your blood pressure falls along with your heart rate, is more indicative of vasodepressor syncope versus an orthostatic hypertension where only the blood pressure drops. A lot of time there is psychogenic syncope, like inversion disorders. So in young women who feel palpitations, I saw one woman who was drinking a lot of caffeine and energy drinks and would go out to run extreme amounts, like 15, 20 miles a day. And she had this positive Tiltable Test and negative Tiltable Test. And once we took her off the coffee, the palpitations improved, right? And she's back to running again, right? So she'll see me as and when likely. So this is a Tiltable Test. Again, you'll put them in the lying down position where there is no gravity, and the patient would have normal blood pressure and heart rate. And as you raise them, whether the heart rate, blood pressure, goes up and patient passes out is sort of what we look at. this is something which is more relevant for the today. Today, I had a young lady, a young patient, patient C, who came in with chest pain one day after getting a COVID booster, right? And she looked like what we called pericarditis, and we did an echo. Her echocardiogram was thickened, and her biomarkers were negative. Remember, we talked about troponin, BNP, and Dr. Singh was involved in the case, so ESR, CRP were normal. But we think she has pericarditis. It got slightly better with colchicine and NSAID. She's still recovering, right? It's too early to say. But if you have any vaccine-induced injury like myocarditis, right? Pericarditis, chest pain, COVID-related chest pain, long COVID, we're happy to see you, right? This is just another way of describing the heart muscle. So what is a plaque which causes heart attack is little cholesterol deposits here, right, in the sides. This just shows the anatomy wall, 3 layers. One is myocardium, there's endocardium and pericardium. The myocardium is involved in myocarditis. So, there are a whole spectrum of patients which I see. So it involves from, like I said, preventative. If I were to divide into 2 categories, would be disease management and prevention. Prevention will be somebody who has risk factors, right? Who has, but is not symptomatic, doesn't have chest pain, shortness of breath, would just like to come and talk about their cholesterol, their family's cholesterol, about healthy eating, what to incorporate to decrease the risk of heart disease 5-10 years from now. People who have disease would be people who are actively having chest pain, shortness of breath, would like to see people want to address their need for hormone replacement therapy. If you feel weak, low, your blood pressure is low, high, all these conditions, right? A special interest of mine, I haven't seen a lot of women patients would be heart transplant and LVADs, right? So if you have a family member that goes to Rochester, has a LVAD or a heart transplant and would want to come see a doctor who's close by, I am happy to see them, right? These are a little presentation I put. I know, it's not very detailed, right? I try to talk about a few patients I have, but this is just general heart disease in general. And remember, as women, we take care of our families. So we are the major, sort of everything falls on us. Yes, as guys make money and, your husband may be working, but you're sort of responsible to make sure everything goes well and, kids doing well. So if you want to come and bring your significant other, if they have questions like the lady. So I'm happy to do that. So it's not just centered to you, but just generally involving family health, right? This is all I have, a little small presentation. I'm happy to take as many questions as you guys have. Right?
Thank you so much, Dr. Chawla. We have 2 questions in the Q&A as well as the questions that were submitted prior. So as you have questions, please feel free to submit them through Q&A and we will go through and answer them. The first question is, I have high, good, and bad LDL and HDL. Is that serious?
You have high LDL and high HDL. So if you're a woman, high HDL, you get 1 good point for a high HDL, and high LDL, yes. Depends on how high it is. So if you want to come down, visit me clinic, we can sit down, talk about it. Generally, in the old scheme of things, was if you have more than 3 risk factors, if you have no risk factors less than 130, if you have more than 2 factors less than 100, if you have heart disease, and so it all depends on what you have, right? So LDL, is your bad cholesterol, so it should be low, and HDL should be high. So you get a good 1 point for the HDL, but it would be canceled by the LDL. So somebody like yourself, if you want to come down and actually bring me your numbers, right? Or we can talk about it, or even make a virtual tele appointment, right? Just to talk about your cholesterol would be good. And things that will lower this LDL will be losing weight, exercise, and sometimes, we do everything and still our LDL is high, and it's okay to take medicine, right?
Thank you so much for that question. So we have a question from Patricia. Is hypertension, well-controlled biomestrine, still a risk factor? If I mispronounced that, I'm so sorry.
Yeah, hypertension is a risk factor. So, when I see a patient for heart disease, when I evaluate them, I look at, what is their pre-test risk for having heart disease. So I will look at their risk factors, like, do you have high blood pressure, diabetes? Do you have a history of stroke, coronary artery disease in the family? Have you smoked, right? It doesn't mean everybody who has high blood pressure has heart disease. You may have high blood pressure and have nothing, right? You may just be fine. But yes, it's a risk factor for developing heart disease in the future. So somebody like yourself, you should probably think about getting an echo, coming and seeing, making sure the heart isn't thick from the high blood pressure. What happens if high blood pressure is not well controlled over time? The bottom chamber of the heart thickens because it has to push against high blood pressure, and the top chamber of the heart can go into atrial fibrillation.
Wonderful, thank you. We have one of the previously submitted questions. If you have very low blood pressure, is salt still bad for you?
No, salt is okay for you if you have low blood pressure. It's interesting. My mom, my parents, my mom has low blood pressure, like 90/50, and my father is hypertensive. Me and my sister both are cardiologists, and we have low blood pressure. So once my sister, it's an interesting story, she got a gym membership. So, initially they give you a couple of sessions, come work out with us. And she almost passed out because her blood pressure went over 70 over undetectable, right? So I have gained a little bit of weight to help my blood pressure. It's like 110 now. But yes, salt is okay for you. Sometimes we wonder, the patient is eating salt before and after. So it's not the salt which causes the high blood pressure. The patient has a disease called high blood pressure, right? So, and you need medicine. So salt should not affect whether you have high blood pressure. I don't think so, right? So they generally recommend 2-gram salt diet for people who have heart failure. But the way I was trained was saying, the patient was eating salt before and after. Now the patient has heart failure. That's what's going on, right? So it's a good idea to eat salt if you have low blood pressure.
We have Adela, and she has a question. Do you think red wine helps lower high cholesterol?
So red wine is interesting. Red wine actually increases the good cholesterol, which is supposed to be high, the HDL. 3 things increase good cholesterol: exercise, red wine, and being a woman, right? So drinking red wine is always a good idea, but it's even a good idea to increase. Red wine is good. If I had to drink something, I would pick HDL, right? So red wine is a good idea. Yeah, it does increase good cholesterol. It doesn't lower the HDL, it doesn't lower the bad cholesterol, but does increase the good cholesterol. What lowers the bad cholesterol is exercise. I used to be, when I was in DC, everybody runs in DC, so very walkable city, right? I used to live by the National Mall, so I was running around the monuments, and that would help increase my LDL. Also, I would take instead of having red meat, I would, when I went to get Thai food, I would take tofu, little diet changes. So if that's something you would like to talk about, you can come see me and we can talk about foods that help lower the LDL, right? More fruits and vegetables, exercise, taking meat out as much, lean chicken or turkey or some things like that, right?
We have an anonymous question. How is heartburn factored into the rest assessment?
So heartburn is a symptom of heart disease. It's not a risk factor. So risk factors for heart disease will be obesity, hypertension, hyperlipidemia, high cholesterol, family history, smoking. So all those are risk factors. What happens with heartburn is one of my aunts, she had heartburn for 2 or 3 days, and they took a little bit of Mylanta or over-the-counter things, and it didn't help. And when she went to the hospital, she actually had she was having a heart attack, and a stent was put in, right? So it's not a risk factor, but a symptom. Like a lot of women do not present with chest pain, shortness of breath. They present with GERD, a lot of anxiety, just feeling different. It's okay to come to a doctor, right? That's one. And it's okay to come to a cardiologist with any symptoms which you think may be out of the ordinary, where, you may think that heart disease is.
And one of our previously submitted questions, in preventing AFib, which my mother had in her 90s, what can we do to prevent AFib as
Yeah.
my mother had these issues?
Yeah, hypertension control is very important in preventing AFib. I've seen a lot of patients who have very hypertensive and they stay hypertensive for a long time. So, going to your regular doctor, making sure your blood pressure is checked is very important in preventing AFib. How do you prevent stroke in people with AFib? So remember we talked about the CHAS-VAS score. So that you get points, and anything 0 is okay to not put on blood thinners. Anything 1, it's up to the physician discretion, 2 or more. You'll definitely be on anticoagulation. So congestive heart failure, hypertension, age 65 to 75, female sex, having vascular disease, diabetes. So more of those risk factors you have, the chances of having stroke is higher, right? I'm not sure how your mom had a stroke in her 90s, whether she wasn't a candidate for, or this AFib wasn't detected. But, if you want to come see me, we can talk more about it. And, just so you would have some idea of this thing, I don't know in what circumstances she had a stroke, right? Why she had a stroke. So if you have,
we have answered all of our questions. Does anybody want to talk or ask their question? Please let me know, raise your hand.
there was one question is, when did I come to Ithaca? So I came on November and it was cold, right? So I've gotten used to the cold. But Ithaca is so beautiful when it snows, but I came in November, right? So, yeah.
And we have an anonymous question. What is an enlarged aorta and how can I learn more?
So enlarged aorta is, anything above 3.6 centimeters is considered enlarged. And when you need surgery is greater than 5.5 centimeters, you can get an echo. You can get a CT scan of the aorta here. One of my partner's patient had a Marfan's aorta, which is a congenitally deformed aorta for the fibrillation gene, and the aorta has elastic issues. So yes, the aorta is enlarged for many reasons. Generally, echo or CT scan helps us measure it, and then we periodically monitor it every few years to every 6 months to a year to see how fast it's enlarging. And greater than 0.5 centimeters per year is considered pathological, right?
We have a question from Carol. Can migraines be a symptom of heart disease?
No, I think migraine is not a symptom of heart disease, but it's a good question. So migraine is not a symptom of heart disease. Sometimes with bicuspid aortic valve, there are several aneurysms, but nothing like that. Migraine is not, it's just some hormonal issues and that causes migraine, but no, yeah, migraine is not a is not a symptom of heart disease. Symptoms of heart disease would be chest pain, shortness of breath, irregular heartbeat, palpitations, GERD-like symptoms. Those are symptoms. What is more important is to prevent them from happening. So if you have any family history of heart disease and you want to know your risk, then you can come see me. For example, somebody who had mom who had a heart attack at 90, let's say, and she wants to know whether she's going to get the same. We will check your cholesterol, we can get a calcium score, we can do some risk factor modification. The whole idea is to prevent it in the long term, right? The first slide said that 1 in 3 women will have heart disease, but 80% of it is preventable.
Della has a question. Can a low-fat diet cause other problems? I know one person who, after starting a low-fat diet, developed ALS. I know low-fat did not cause it, but maybe lowered his defenses.
Yeah, so there's a new medication for cholesterol called Repatha, right? And some people say the more you lower the LDL, older theory was it caused demyelination, but I don't think so. It causes it causes anything like that. You know, what a good diet for heart disease will be more salads, salads without dressing, to take little things away. I used to eat a lot of salads without dressing, a lot of fruits and salads. You know, 2/3 of my plate will be full of fruits and salads. At least eat an apple a day, oatmeal for breakfast, right? You know, run. I've stopped doing these last few years, but yeah, those are, you know, little changes. You know, if you want to eat out, not eating out every day, right? So yeah.
An anonymous question submitted. I've recently started having GERD symptoms. Should I be concerned?
Yes, and you know, if you have GERD symptoms and they send you to a gastroenterologist first and it gets better, then the answer is no. But if you have GERD symptoms and it's not better with your GERD medication, then yes, that's a sign of heart disease, right?
Myra, one moment. Myra, you should be able to talk now. You may need to unmute yourself.
How often should your cholesterol be tested?
It's every once a year is a good idea. Then if you have other risk factors like diabetes, every 6 months or so is a good idea. But at least once a year, you should get your cholesterol tested just to see where it is, right? I like personally, you know, because I'm a cardiologist, I think I'm just, there are guidelines. We have ACC guidelines on how to control, you know, there's an ASCVD risk score, and whether it's greater than 7% or it's 5% or 20%, we sort of recommend cholesterol lowering medicine. But I like for myself, my LDL to be below 70. So, you know, if it is more than that, doesn't mean I have heart disease, but I just try to, you know, it does mean that I just need to make some lifestyle changes, right? So, so that's essentially LDL.
Thank you, Myra, for your question. We have a question from the Q&A panel. Do you think people should always use the upper arm traditional home blood pressure monitors? Someone gifted me a newer type of blood pressure monitor that goes on the wrist. It seems to be less accurate. What type of home blood pressure device do you think is best?
Yeah, the wrist ones are less accurate, but the cuff ones are more accurate. If you have, you know, another thing you can do is local CVS or local pharmacy, you can check your blood pressure and you can check with your cuff and you can compare the two and see that they're same reading. You can also bring in your blood pressure cuff to our office and, you know, you can get some readings and we can check with both your cuff and ours and say, so wrist is generally inaccurate, right? And yeah, wrist is generally inaccurate.
I open the floor. If anybody has questions, go ahead and raise your hand and I will unmute you. Patricia has a question. What do you like your HDL rating to be?
Yeah, generally there's a certain cutoff for women, you know, greater than, higher the better, right? So if it's 70, great, but at least above 50, right, would be a great idea, right? For women, the higher the better, right? And more exercise you do, if you're premenopausal, that's what happens in postmenopausal women. Their HDL goes down and the LDL is high. So that's sort of the risk factor. As long as you have hormones, your HDL is high, right?
I have a question. What are some of the things that people can do at home today to help monitor their heart health?
So eating healthy is generally good. You know, if you want to Google low LDL, foods which lower your LDL, generally, my thing has been more fruits and vegetables, a lot of activity. So walking at least 10,000 steps a day is a good idea. We all have the iWatch. So you can count your steps, walking 10,000. It's hard here, especially in the winter, but now that the weather's coming up, walking 10,000 steps a day, maybe even adding a little bit of exercise. And if you think 10,000 steps is a lot, I mean, starting slow, right? Slow and steady wins the race, like I said. So, even if you want to walk on a treadmill, maybe 5 minutes a day, and then over a month, you can go up to 10 minutes a day. Then the next year, you can go up to 30, but just incorporating exercise in your daily regimen would be a good idea. Eating healthy would be a good idea. Quitting smoking would be a good idea. If you have risk factors, maybe getting a calcium score here is a good idea. And then, we can risk stratify you, but eating healthy and exercise are two key ways of preventing heart disease, right?
Again, if you have any questions, you can type them into the Q&A section, which is located on the bottom of your screen. You can also use the raise your hand feature, and I will take you off mute so you can talk. An anonymous submission. If I quit smoking in my 30s and I'm now 60, is my prior smoking considered a risk factor? It's a great question.
Yeah, it is considered a risk factor. So if you've smoked for a little bit of time, it is definitely a risk factor, but it doesn't mean that you have heart disease, right? So your LDL could be fine. For somebody like yourself, a calcium score would be a great idea to bring, right? Your score and see what it is. But yes, smoking for a little bit. Not every smoker has lung disease or heart disease, but it's considered a risk factor. You can look at your LDL. So if you smoked, generally your LDL should be less than 70, right? So yeah.
Again, if you would like me to take off mute, just go ahead, put your hand up, type your questions in the Q&A. I'm watching the Q&A and the chat section. I want to make sure I capture all of your questions. Myra, go ahead and unmute yourself. You should be able to talk.
Are we going to go into any medications with the talk?
Yeah, so, I can talk about generally for preventative, for cholesterol, it would be hypolipidemic medicines like statins, and they will, they generally have side effect of liver dysfunction. So we check your LFP so often, like I said, there are 4 things in a cholesterol that I look for: total cholesterol essence, 200, triglycerides optimally less than 150. Now they're saying 170, LDL below 70, and then HDL, right, above a certain level. So at some point you end up being on medication because you've done everything right, you've changed your diet, you walk, but it's still not getting better. If you have calcium score or plaque on calcium, then you can be put on aspirin, right? If you have disease, then that's disease management. If you have atrial fibrillation, heart failure, arrhythmias, and that's disease management. And the whole spectrum of drugs is different, right? But generally for primary prevention, for somebody like yourself, Farah, if you're asking, I don't have heart disease, what's going to happen to me if I come to the doctor's office? You know, you can check your cholesterol. One of my patients was a nurse here, and she had high cholesterol, and she thought, you know, her physician wanted to put her on statin because they thought it was genetic, and she had genetic because she's regularly exercises and she's very good with it, but she likes red meat. And, you know, for 6 months, she cut red meat and her cholesterol became normal. So she doesn't need medication. Everybody's different. The lifestyle is the first mode of treatment. And if that doesn't work, then this, right?
Wow, we've got wonderful questions coming in through Q&A from Adela. How does diabetes damage the heart?
So diabetes is, you know, somebody who's diabetic is considered as equivalent to heart disease. So it's considered you have heart disease. So your cholesterol should definitely be less than 50. Like diabetes can damage kidneys, eyes, and eventually cholesterol builds up. So diabetes and cholesterol is like type 2 related with obesity, right? And yeah, and that sort of builds up, right?
I have a question from Carol. I believe the question is about insurance. So we're going to do our best to answer it. If you need clarification, just go ahead and rewrite the question in the Q&A section. Do we need a referral, or is that an insurance related question? So I'm wondering if she needs a referral to see a cardiologist.
So I don't know about the referral, right? I defer it to your primary care physician, so you can talk about it and you can say, you know, I would like to see a cardiologist just to do risk management and, you know, risk factor identification. Maybe I have a family history of heart disease. I don't know how insurance works, right?
From an anonymous, is heavy drinking or alcoholism a risk factor for AFib or heart disease, or is it only indirectly because of the weight gain?
No, weight gain is one, and alcohol is also, you know, we call it holiday heart, and people drinking a lot of alcohol over the holidays, and they have heart disease, right? So, so yes, alcohol by itself can cause atrial fibrillation. It's transient. I see a lot of young people, you know, they get drunk, like binge drinking, and then they develop atrial fibrillation. Once they come off the medic, you know, they don't need blood thinners because, you know, their chances of having that is less. Their heart is normal, right? And that can happen by itself, right? Alcohol by itself can cause atrial fibrillation. We call it holiday heart. That means once you stop drinking, the heart is fine and you don't need blood thinners for it, right? But if you have other risk factors like hypertension, high cholesterol, stroke, diabetes, then you may need heart. Yeah.
This question is from Julie. I have had viral pericarditis and I'm being monitored once a year by a cardiologist at Cuba Heart Center, and I have had wonderful care. How long should I be monitored, and what else besides getting an echo and EKG at these early appointments should I ask for? I'm 58 and eat well and exercise as much as I can.
Yeah, so you know, you're doing everything right. So what happens is once you have pericarditis over long term, the question is, are you going to get constrictive pericarditis? Because are you going to get recurrent symptoms? So no, echo and EKG is fine, and that's your cardiologist is doing everything right.
We have a question from our
I'm going to unmute you.
Brianna. I'm going to unmute you. So just double check that you are.
Okay, I guess I had to unmute. I was wondering, you know, if you have like mild valve problems, can they go away at some point? Like AFib can, you know, sometimes go away, just be temporary, or does it progress? And if it progresses, you know, how long does it take it to progress, like say to moderate?
So AFib can be, you know, something which is permanent. That means it's always there. or it comes and goes. Like it's there for a little bit, but you definitely need, to assess your risk for anticoagulation, blood thinners. You should definitely see a cardiologist. In terms of valve leak, mild, moderate, and severe, that's how we classify. So mild is generally you'll follow every 3 to 5 years. You'll check an echo. Moderate means in a year. Severe means 6 months, right? So mild to moderate will be, so depending on symptoms. I had a gentleman who has high blood pressure, was in control. One of his aortic valve in Maryland started leaking, and we put him on he developed heart failure, shortness of breath, and his ventricle was a little weak. And so the surgeon went and operated. So in terms of valve leak, we decide when the surgeon's going to operate, and for atrial fibrillation, we decide when to give blood thinners. So both things you'll need to see a cardiologist. And it doesn't mean if you have mild valve leak, it will progress, or if you had atrial fibrillation once, it may never happen again. But it all depends on, yeah.
Thank you.
Yeah, thank you. Yeah, I mostly, I worked for many years at Georgetown, mostly as a transplant cardiologist, and it's nice to hear from patients. I dress up, and one of my colleagues was from Argentina, wearing a woman cardiologist. I like women surgeons, women cardiologists. So she had very long earrings, and a couple of times I would wear these earrings and come to work, and I thought nobody notices me but myself, right? And then this patient wrote a book called Shelley's Heart, right? It's about her transplant experience, and it talks about me. I'm Dr. Lily in that book. And she remembered exactly what I wore. So every time I read her story, I remember the day I dressed up and went to work. So it's nice. It's nice. Patient-doctor interactions are very nice for me. So I enjoy them.
A question from the Q&A section. Adela, can you mention any natural remedies used in India to treat high cholesterol?
So I don't know. My parents generally will say, this is Western medicine, and they will want to try, but a lot of people talk about garlic, right? A lot of garlic in your diet, and that lowers cholesterol. But I believe in Western medicine. So I believe taking anti-cholesterol medicine, but tea, herbal tea, garlic, right? So yeah, is generally good for your heart health, right? Tea can cause sometimes palpitations and to moderation. I drink tea over coffee because coffee gives me palpitations, like the Starbucks latte. Started drinking now, but I generally tend to avoid them. Generally get green tea, which is Japanese, is nice, right? So yeah, they talk about garlic, but I don't think it works. My parents talk about. My father had prostate disease, and for many years kept thinking he would take herbal remedies, and it did not work. Eventually he had surgery and he feels much better. So I would stick with Western medicine. Right?
We'll go ahead and take any last questions that you may have. Again, please raise your hand. You can also put your questions in the Q&A section. Jacqueline, we got you. Jacqueline, it appears that you have an older version of Zoom. If you want to send me the question that you have in chat, I'd be happy to answer that question for you. while we wait for Jacqueline's question, I have a question. Can you talk about how stress affects heart disease?
Yeah, we have something we called Takashima syndrome, and that's essentially heart failure, which is sort of reversible. So a patient has, wall motion abnormalities, heart failure, low ejection fraction, and that's generally seen in women with stress. You put on medication, some of it gets better. So yes, stress does cause heart disease, right? And so it does cause heart disease, and also stress in people who have enlarged aortas, hypertensive, can cause dissection. So yes, generally stress does affect. It's okay not to be stressed, right? About anything and relax, which is hard, but it's doable, right?
Thank you, Jacqueline, for your question. Jacqueline's question is, could you mention mitral valve prolapse? Did I say that right?
Yes, it's generally seen in women, and it's one cause of young women having chest pain, right? So that's mitral valve prolapse. In older times, there used to be medication for endocarditis, but now there is none, right? So now there is no medicine. Generally, we monitor for leaky valves. If it gets leaky to a point where it needs surgery, then we do it. So bileaflet prolapse is called Barlow syndrome. So yes, there is mitral valve prolapse, right? I'll be happy to see patients with mitral valve prolapse.
We have a question, Rihanna.
I guess I have to unmute. Okay, I was wondering about the statin controversy.
For high cholesterol, so statin is indicated at a certain point. We put in a risk factor score, and then we decide whether it has to be in statin or not. But you can do lifestyle changes. A lot of my patients get better, just with by doing on diet, right? But if your cholesterol is high, especially if you're diabetic or have other risk factors for heart disease like cigarette smoking and diabetes, it's almost like having coronary artery disease. Then you have to be on cholesterol lowering medicines, right?
Okay, so that means then in some cases you can just do it with diet or exercise, and other cases you actually do need the statins. Is that
That's
correct?
Correct. There is like primary and secondary prevention. So for example, somebody had a heart attack, or somebody's diabetic, or somebody has a leg disease or a cigarette smoker, then it's almost like having heart disease. So you'll be on statin. But let's say you came and saw me and your LDL is 125, and I'm not going to put you on statin. You have no risk factors. You ideally would like to be lower. So you can just try a diet for 6 months. And a couple of my patients, at least one patient here, I've only been here since November 29th, but one of my patients was a nurse at the hospital, and she got better. She was extremely thin, and she came to me one day, and then I was talking to Dr. Singh, and she initially said her cholesterol is really high. She was adopted, so she doesn't know if it's familial, right? Which is also an indicator. So I found about University of Rochester where to do familial. So we went in all these different directions. And then I told her, why don't we see diet? So she was eating a lot of red meat, and she said, she would like to do more salads and fruits, and her cholesterol got better, right? To a point where she doesn't need medication. So hers was diet related, right? Generally when it's diet related, you'll see high triglycerides. So yeah.
Okay, thank you.
Yeah, no.
We are at 6:34. I want to thank everybody for coming today. On behalf of myself, Dr. Chawla, Dr. Singh, and everybody at Kuga Health, we very much appreciate your time. Dr. Chawla is seeing new patients. If you are interested in making an appointment with Dr. Chawla, the telephone number is 607-275-9739. Again, that's 607-275-9739. And we will be sending this presentation out to you as a video so you can watch it on your time as well. Thank you again, everyone.
Thank you.
Thank you.